welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our next presenter is Elijah Allen. He's a PGY2 critical care resident at CoxHealth, and he'll be presenting on isotonic balanced fluid versus 0.9% saline in patients with moderate to severe traumatic brain injury, a double-blinded randomized control trial.
Just to give a brief background on TBI itself, traumatic brain injury is defined as an impact, penetration, or rapid movement of the brain within the skull that results in an altered mental state. And we have two stages of injury with this. We have the primary injury, which is the actual mechanical harm that gets imposed on the brain at the moment of collision. And this is what you typically expect patients with the TBI to present with: an intracranial hematoma, skull fracture, brain contusion. And then you have the secondary injury that develops as a consequence of that primary injury. And this can present in a variety of ways. Commonly, we'll see mitochondrial dysfunction, excitotoxicity, oxidative stress, and we'll also see cerebral ischemia, increased intracranial pressure, and cerebral edema. And this is what we'll really be focusing on today. Now, in a healthy brain, we have a way in which that we can help regulate our cerebral perfusion pressure through a process called cerebrovascular autoregulation. And that's working to help maintain an adequate cerebral perfusion pressure. And the goal in a TBI is to prevent hypoperfusion, which can worsen that cerebral ischemia, while also preventing hyperperfusion, which could worsen an intracranial bleed or that cerebral edema. And one of our goals of therapy in treating patients with TBI is to help maintain this process through the use of fluid resuscitation, fluid maintenance, and hyperosmolar solutions. And this is just a quick table giving a variety of what fluids that we can use in our fluid maintenance and our fluid resuscitation. And so this gives a summary of the components of normal saline compared to our balanced fluids and how they compare to human plasma. Now, on the far right, you can see the fluid abbreviated SF, which stands for sterofundin. And this likely isn't a fluid that you've commonly heard of. It is considered to be a balanced fluid, and it's used more in our Asian and Asian Pacific island countries, but nevertheless, it is considered a balanced fluid. Now, just to point out some key differences between sterofundin and some of the other fluids that we'll be talking about today, looking at the osmolarity of it, its osmolarity is actually much more similar to normal saline in that it is slightly hypertonic in comparison to human plasma, whereas the balanced fluids, lactated ringers and plasmolite, which we are more commonly seeing, tend to be either isotonic or slightly hypotonic. And this gives a theoretical advantage to normal saline and sterofundin in that it is slightly hypertonic, which can help prevent or reduce that cerebral edema. And then the other thing to note is the chloride components of the two. So normal saline is noticeable for having a pretty high chloride value, whereas our three balanced fluids tend to have a relatively lower amount of chloride. This is advantageous for a couple of reasons to have a lower chloride value. There is some evidence out there that exists that shows that when putting a cell in hypotonic media, it actually activates chloride efflux pumps, which helps pump chloride out of the cell, which can theoretically reduce cell swelling. The other advantage of giving patients less chloride is that it decreases the risk for developing a hyperchloremic acidosis, which can lead to an acute kidney injury. And so our three balanced fluids having that less chloride component could potentially be an advantage over normal saline. So on paper, when you compare all of these fluids, sterofundin actually has like the most ideal profile in managing a patient with traumatic brain injury, as it does have that hypertonicity that can prevent that cerebral edema, as well as a lower chloride component that can help reduce that risk for hyperchloremic acidosis. Now, looking at our 2016 Brain Trauma Foundation guidelines, they do recommend targeting a cerebral perfusion pressure of 60 to 70 millimeters of mercury, but they don't make any recommendation on the optimal fluid choice to try and achieve this. So what does the actual literature say? So looking at our first study here in 2013, this was a double-blind randomized controlled trial that looked at isofundin versus normal saline. Isofundin is pretty identical to sterofundin, it's just under a different name. I looked at patients who had a severe traumatic brain injury who were on mechanical ventilation within 12 hours after injury. And it looked overall at mostly lab parameters, and it found that patients who were on normal saline had a significantly higher hyperchloremic acidosis than patients who had isofundin. You can probably note that both of those values are pretty high in both groups, and that's probably due to the way that they defined their hyperchloremic acidosis, which was defined as a strong ion deficiency and a chloride of over 108. So not a very specific way in which they define their hyperchloremic acidosis, so a lot of patients were probably triggered. But in the study, they also found that there was no difference in intracranial pressure, intracranial hemorrhage, or craniectomy. The RAL trial, which came out in 2016, was a prospective observational trial that came from patients who were included in the PROMPT trial. And this looked at lactated ringers versus normal saline in patients who had a TBI with an ISS of 9 or greater, who received at least 200 mils of pre-hospital fluid and at least 1 unit of red blood cells within 6 hours of admission. And in this study, they found that lactated ringers was associated with an increased 30-day mortality compared to normal saline. However, it should be noted that the LR group did have a higher injury severity score, as well as a higher rate of pre-hospital intubation. So these patients likely had a greater injury prior to arrival. In 2017, Hassan came out with a double-blind randomized controlled trial that looked at normal saline versus sterofundin in patients who had a severe TBI and who required an emergency craniotomy or craniectomy and who were ventilated for at least 24 hours. And once again, this study also just focused on lab parameters, and it found that with normal saline, it was associated with a decrease in base excess and bicarb levels and an increase in hyperchloremia and hypokalemia at 24 hours, whereas sterofundin was only associated with an increase in magnesium and calcium levels. Now, while all of those results were statistically significant, there was definitely some concerns on whether or not they were clinically significant, as there wasn't much difference between the actual values themselves. In 2022, Lombardo came out with a sub-analysis of the Hallmark SMART trial that looked at balanced fluid versus normal saline in patients with TBI. The way in which they identified these patients with TBI was strictly by billing codes, so there wasn't really any inclusion criteria that had to be met. The study found is that there was no difference in 30-day mortality. However, the balanced fluid group was more likely to die or be discharged to a medical facility, whereas the NS group was more likely to be discharged home. And these results were significant because they differed from the SMART trial itself, which showed that balanced fluids had an advantage over normal saline in patients admitted to the ICU. And then in 2022, that trial by Zampier was a sub-analysis of the Hallmark Basics trial, which looked at plasmite versus normal saline in patients who had a TBI who required at least one fluid challenge and also had risk factors for an AKI and were without discharge in 24 hours. And in this study, they found that once again, balanced fluid was associated with an increase in 90-day mortality. However, when looking at the subgroups that really drove that outcome, it was only in patients who had a SOFA score of 4, which correlates to a GCS of less than 6. So it was really only in our severe TBI patients where they saw this difference. And then that last study was a meta-analysis that came out in 2022 assessing balanced fluids overall versus normal saline. And in this, they included 3 trials in their TBI analysis. And in this study, they also found that there was a decreased mortality in patients who were receiving NS compared to patients who were receiving balanced fluids. And this also differed from the non-TBI analysis that showed that balanced fluids was actually superior in decreasing mortality compared to NS. And so just giving a quick overall summary of this literature, you can see that kind of what we mentioned before, balanced fluids may potentially be associated with an increase in mortality due to that increase in cerebral edema, whereas use of normal saline in these patients may be associated with an increase in hyperchloremic acidosis. And that really brings us to our study today, which looks at sterofundin versus normal saline in patients with moderate to severe TBI. The objective of this trial was to evaluate the effects of sterofundin versus normal saline in moderate to severe TBI. Looking at our outcomes, the primary outcome was in-hospital mortality, whereas secondary outcomes were 3-day biochemical levels, which were predominantly just the typical labs you would see on a BMP and an arterial blood gas, mean intracranial pressure, duration of mechanical ventilation, length of ICU stay, 6-month GOSE score. The GOSE score is a tool that's used to assess global disability and recovery after TBI, and then also the incidence of AKI as well, which was defined by KDIGO criteria. And so you can see that this is really the first study to compare sterofundin versus NS in longer-term outcomes, not just to focus on those lab values. This study took place from 2017 to 2019 and was a double-blind randomized controlled trial. It took place at a single center in Malaysia, and they did sample their patients from the emergency department. Patients were randomized in a 1-to-1 ratio, and treatment was initiated in the ED, and it did follow the 2016 Brain Trauma Foundation guidelines. All patients were assessed by the neurosurgeon. They were either indicated for conservative management, intracranial pressure monitoring without surgical intervention, or needing surgical intervention. Study fluids were used for both maintenance and volume resuscitation and were administered as either a continuous fusion or a bolus at a rate set by the physician. Other isotonic fluids were not allowed during the study. However, they did allow blood products, colloids, and hyperosmolar solutions as well. And then these fluids were administered for up to 72 hours after presentation. And then after that 72-hour mark, fluids were no longer controlled. As I said, hyperosmolar therapy was allowed in the study. And at this institution, they used mannitol at a dose of 0.5 grams per kilogram and were given boluses for intracranial pressure over 20 millimeters of mercury. And the patients who did require mechanical ventilation were sedated with both fentanyl and midazolam. Analysis used, if it was parametric data, it used an independent t-test. If it was non-parametric data, it used a Mann-Whitney-Hugh and independent samples Hodges-Lehman test. Binary values use a relative risk with 95% confidence interval, and our categorical variables utilize a Pearson's chi-square or Fisher's exact test. And all of these tests were appropriate for the data analyzed. Alpha was set as 0.05 and beta was set as 0.2. And overall, 74 patients were required to meet power. Looking at our inclusion and exclusion criteria, patients included in the study were of 18 to 65 years old with a non-penetrating TBI. A non-penetrating TBI was defined as the acute insult to the brain caused by a blunt trauma with no evidence of a pierced skull. The reason for which they excluded patients who were over 65 is that treatment in that older age group is usually more conservative. And so the mortality rate may reflect overall treatment decisions rather than the fluid therapy itself. GCS had to be less than 13 to kind of categorize that moderate to severe TBI group. And then patients had to be recruited within 12 hours of presentation. Exclusion criteria were mostly things that would cause an injury to be considered as non-survivable. Also, if patients were pregnant or if they had any sort of intracranial bleeding that was non-traumatic. And then looking at our baseline characteristics, you can see that overall there were 70 patients included in this final analysis, which you can see just fell short of the number required to meet power, which was 74. But overall, patients in the study were young. They were about 27 years old. They were predominantly male, suffering from a motor vehicle collision, and they had about a GCS of 8 on presentation. Now, just to highlight some of the significant differences between the two was primarily the percent of men. So in the normal saline group, it was 100% men versus about 87% in the steroid group. And then there was also a difference in the abbreviated injury score at baseline for chest specifically, it being slightly higher in the steroid group compared to the normal saline group. Now, just to highlight some other differences that are not clinically significant, but overall, I felt like were important in pointing out. Looking at our Marshall CT classification, the Marshall CT score is a CT scan derived metric that is used to predict outcomes in TBI. And essentially, the higher the value, the more severe the TBI is and the worse the outcome would be. And you can see that in the Marshall CT2 classification, there was a higher incidence of patients who had this class 2 classification with sterofundin compared to the CT classification score of 5, which was higher in the normal saline group. But once again, I would like to point out that that was not statistically significant. There was also some difference in the injury severity score, with it being 34 in the normal saline group and 39 in the sterofundin group. This was also not statistically significant. And when we look at their overall Apache score on arrival, it was pretty similar between the groups. Looking at the fluids administered to these patients in the normal saline versus sterofundin group, overall, it was pretty similar between both groups. There wasn't any statistically significant differences in fluid administered. The total input over the 72-hour period was about 9 liters, most of it being crystalloid fluid. Both groups did receive a little bit of normal saline prior to randomization. You can see in the sterofundin group, it was only about 600 mils. It wasn't even a liter. So taking that into account in comparison to all the other fluids they received, it likely didn't have too much of an impact on overall results. And then after randomization, you can see once again, the study fluids administered were pretty similar between groups, as well as the use of hyperosmolar therapy with mannitol with it being about 10% in each group. Additionally, looking at the urinary output and the fluid balance between groups, these were also pretty similar and were not statistically significant between each group. Looking at our results, first off, focusing on the parameters, there was no really clinically significant difference other than in the intracranial pressure on day 3, which was slightly higher in the sterofundin group compared to the normal saline group. However, when we look at the cerebral perfusion pressure, this was not statistically significant between the group. You can also see that there were no differences in complications, such as in AKI or renal replacement therapy. There was actually no incidence of AKI or the need for renal replacement therapy in either group. The likely reason for this was probably due to patients being so young, with the median age being about 27 years old. They likely had pretty good kidney function at baseline and were probably less likely to have this incidence of AKI or a need for dialysis. And then focusing on our primary outcome and other in-hospital outcomes, you can see that there was not a statistically significant difference in the in-hospital mortality or in any of our other in-hospital outcomes. There was also no difference in the GOSE score. However, it did trend towards favoring normal saline over sterofundin. So you can see in the unfavorable group, or in patients who were discharged with an unfavorable outcome, it was lower in the NS group versus the sterofundin group. And then in patients who were discharged with a favorable outcome, it trended towards favoring normal saline over sterofundin. Once again, these results were not statistically significant. And it should also be noted that a lot of these patients were lost to follow-up, which could be impacted by survivorship bias. So 55% were lost to follow-up in the normal saline group and 43% were lost to follow-up in the sterofundin group. You can see at the bottom are 3-day biochemical parameters. So of all the parameters that were taken and analyzed, there was only 3 that were found to be statistically significant, and that's what is indicated in that box there. And you can see the pH at baseline was 7.34 for NS versus 7.3 for sterofundin. And the base deficit on day 1 was 2.9 for NS versus 3.9 for sterofundin. And the potassium on day 2 was about 3.8 for NS versus 4.09 for the sterofundin. Now, while these were statistically significant, you can certainly question their clinical significance, as most of these labs are still within range. And we didn't see differences on any of the other days or for the area under the curve overall. And the other thing you'll notice is that there wasn't any difference in the chloride value as well. The highest that chloride ever got in either of these groups was 109, so there really wasn't any incidence of hyperchloremia in either of these groups. Looking at our author's conclusion, they concluded that in patients with moderate to severe TBI, sterofundin was not associated with a reduction in in-hospital mortality, AKI, or improvement of GOSE score at 6 months. They do agree that further studies on the effects of balanced solutions, such as sterofundin, on long-term outcomes, such as mortality and quality of life, are warranted. Strengths of this trial was that it was double-blinded, it was a randomized controlled trial. They did have adequate inclusion and exclusion criteria to assess the impact of fluids on our patients. While I did point out some of the differences in baseline characteristics, I don't think any of them were so different that they actually impacted the results. So I think the baseline characteristics were pretty similar overall. Limitation to this trial is that this protocol for the trial was actually amended in 2018, so kind of in the middle of the trial period. Originally, it was supposed to just be isolated TBI cases to really assess the impact of fluids on traumatic brain injury. However, because of a low recruitment rate, they did end up including polytrauma cases as well. As I mentioned earlier, power was not met, and because we did not meet statistical significance, we cannot rule out a type 2 error. Did utilize Marshall classification in their baseline characteristics. We know now that Rotterdam criteria tends to be preferred over Marshall classification. The Rotterdam criteria is also a CT-derived metric. However, it takes into account the different types of injury or the different types of intracranial bleeds. So it's a little more of a robust predictor of mortality and outcomes in TBI than Marshall classification. There was the receipt of normal saline prior to randomization. As I mentioned earlier, though, it was only about 600 mils of normal saline in the sterofundin group, which when looking at the amount of fluid that was administered over this 3-day period, it's likely not to have a very significant impact on the results. As I also mentioned, there was a high number that was lost to follow-up, which can certainly impact our GOSE score, especially due to that survivorship bias. And then overall generalizability of this trial is pretty poor. So this was done at a single center in Malaysia, which makes it hard to extrapolate this data to other institutions here in the US. Also, seroflonin, of course, is not a fluid that we commonly use here in the US. That doesn't mean there's no reason we can't advocate for it to be here if it was superior to normal saline. But overall, it's not a fluid that providers are going to be commonly used to using, or one that we can just routinely grab. Additionally, there was like a low use of hyperosmolar therapy. It was only about 10% in each group. And they utilize mannitol as their hyperosmolar solution, whereas most institutions in the US are kind of made the switch to using hypertonic saline. And the last piece of kind of that generalizability component is that they sedated their patients with midazolam and fentanyl. And here we commonly use propofol for our sedation. And propofol has the advantage in traumatic brain injury of helping decrease intracranial pressure. So the fact that we're using propofol here, whereas they might not be using it there, is certainly something that could impact these results. But the key takeaways from this trial is that seroflonin does appear to be at least a safe alternative to normal saline and TBI. It's not associated with the poor outcomes that other balanced fluids are. However, at this time, I wouldn't recommend any current changes to practice. It hasn't been shown to be superior to normal saline, and fluids like normal saline are much more familiar to our providers, commonly and readily available, cheap to use. So at this time, I wouldn't recommend any current changes to practice, and using normal saline as our preferred fluid in patients with TBI. And so with that, thank you for your time. And what questions do you guys have for me?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.